So Bill gave a really nice introduction yesterday to the importance of the androgen receptor, and I'll just talk, and I'll apologize now if I don't have your favorite molecule on there that can be used to co-target the androgen receptor. But as you know, androgen deprivation therapy is the principal treatment for the disease. The target is the androgen receptor, nuclear hormone receptor, which has a variety of domains, including a C-terminal ligand binding domain, which is engaged by androgens, testosterone, dihydrotestosterone, and antiandrogens like apalutamide and enzalutamide. So despite using hormonal therapy, eventually the disease progresses to the castration-resistant phase, and we now know by work by a variety of groups at Roswell Park, University of Washington as well, that if you examine castration-resistant metastases from patients and you measure levels of androgens, they're very similar to the levels that one might see in a tumor that's never been exposed to medical castration, and that's probably due to a combination of adrenal androgen synthesis in addition to intratumoral androgen synthesis. And we now know clearly that these persistent androgens are a target because of the improvement in survival with drugs like abiraterone and enzalutamide. So these are the principal ways that we currently have to block these persistent androgens within the tumor. Decreasing androgen synthesis, abiraterone obviously approved, enzalutamide and apalutamide also now approved to compete with androgens for AR activation. And there are other drugs of these classes currently in clinical testing. So I'll just talk. I'll try and focus this more on enzalutamide. I think if we to try and cover abiraterone resistance as well in a 10-minute talk would be quite difficult. But we know a little bit about the flavors of enzalutamide resistance. We would predict that these would be similar with apalutamide based upon the preclinical data that's been described to date. In terms of de novo resistance, reciprocal feedback with the PI3 kinase pathway. If you suppress either, you may activate the other. Recent work from Vancouver describing alterations in p53 and cell-free DNA being associated with a lower likelihood of response to enzalutamide or abiraterone. And then in terms of acquired resistance, the emergence of splice variants, ARV7 or others, gain of function mutations in the ligand binding domain, including F877L, which can lead to enzalutamide agonism, which is present in single-digit percentages of patients progressing on enzalutamide or apalutamide. Glucocorticoid receptor maintaining androgen receptor activity, and then other mechanisms including lineage plasticity or transdifferentiation, which are probably not dependent upon the androgen receptor anymore. So this is work by Charles Sawyer's group and Vivek Arora from several years ago, where they looked at enzalutamide-resistant cell models, including those that had AR upregulation or overexpression of AR. And one of the most commonly upregulated genes they saw in their resistant models was the glucocorticoid receptor, and they could also show, even with short-term enzalutamide treatment, you get dynamic upregulation of the glucocorticoid receptor, which can compensate for the androgen receptor, bind to similar sites, and maintain the AR syndrome, or the target genes the AR turns on. And targeting the glucocorticoid receptor with shRNA in vitro and in vivo could suppress the growth of enzalutamide-resistant cell models. So this appears to be an interesting target based upon the preclinical work. There isn't a great amount of clinical data describing this as a target. Nonetheless, there are several clinical trials underway to target the GR. Mifepristone, a clinical trial being led by Rush Smelovitz, and then also a upcoming clinical trial from Corcept with their glucocorticoid receptor antagonist. So it'll be interesting to see how these trials pan out, whether or not this is something that one would expect to only work in a subset of patients, and is there a need for stratification? I would argue yes, in terms of determining who's most likely to respond to this therapy. I think another interesting class of agents to try and block the androgen receptor function are bet-bromodomain proteins. This is one of the proteins we study in our lab that are chromin and reader proteins that sort of act as a crossing guard, if you will, to help transcription factors act where they bind in the DNA. And so work by Arul Shanayan's group showed several years ago that the bromodomain protein BRD4 cooperates with the androgen receptor. They co-associate it at similar regions in the genome. If you use tool compounds like JQ1, which is a bromodomain inhibitor, developed by Jay Bradner, you can block the association of the androgen receptor and BRD4 with each other, and also displace them from chromatin as a way to try and shut down the androgen receptor function. And so they showed in their studies that if you look at model systems treated with this bromodomain inhibitor, you can reduce expression of AR target genes, and you can also suppress tumor growth to a greater extent than enzalutamide in this model. We also looked at this in cell lines that have a gain-of-function mutation of the androgen receptor, this F877L mutation, in which case enzalutamide actually increases AR signaling. It's very similar to dihydrotestosterone. But if you co-treat at the same time with a bromodomain inhibitor, you can essentially abrogate that effect and prevent PSA from going up and shut down AR signaling. And if you treat these models with either enzalutamide alone or enzalutamide with a bromodomain inhibitor, you can prevent that agonism by enzalutamide and prevent tumor growth. And so there are several ongoing clinical trials with bromodomain inhibition, one from Zenith Epigenetics that we're participating in, and then Insight Pharmaceuticals also has a phase 1 clinical trial in all comers, including those with prostate, to look at the activity of this drug in resistant patients. N-terminal AR inhibitors are another area of development. This is a compound developed by Marianne Sadar in Vancouver called FE001 that they published on several years ago that showed suppression of tumor growth in a castration-resistant model. There have been a variety of different formulations or analogs of this, including one called EPI-506 that was in clinical trials with ESSA. I don't have a lot of information on that trial. When I look at clinicaltrials.gov, it said the trial was terminated due to
it's dead.
Due to excessive pill count. So this does not look like a tractable option to block the androgen receptor. There are other groups developing N-terminal inhibitors, including our Cherkasov's group from Vancouver. So I think it is an exciting area, particularly given that the splice variants have an intact N-terminal, and this may be a way to block both full-length and splice variants. I think another interesting area is the PROTAC technology developed by Craig Crew's group at Yale, where you can essentially target proteins specifically for ubiquitin proteasome-mediated degradation. This is some of the work that they've presented in poster form only. I haven't seen any manuscripts yet on their AR degrader, where in a variety of different cell model systems using quite low concentrations, you can lead to targeted degradation of the full-length androgen receptor, and you see similar anti-tumor activity in a VCAP CRPC model as one does with enzalutamide. So I think this is another exciting area to keep an eye on that would be predicted to block full-length AR function. This targeted degradation signal binds to the ligand binding domain, at least for their technology, and so it does not affect the splice variants. But to the extent that splice variants depend upon full length for function, this may be a good way to shut down splice variant wild-type heterodimer signaling. So I think in conclusion, preclinical models, patient tumors demonstrate that AR signaling remains an important target despite drugs like enzalutamide, abiraterone, apalutamide. Glucocorticoid receptor antagonists are currently in clinical testing. Bromodomain inhibitors are in clinical testing. A variety of groups are trying to target the N-terminus of the androgen receptor, and we'll see, hopefully, PROTAC directed therapies also enter the clinic in the next few years. So happy to stop there and take any questions.
So some of the best responses I've seen in CRPC post-enzalutamide have been with a strong glucocorticoid agonist. So how am I going to justify giving patients a strong glucocorticoid antagonist? Answer that for me, please.
Yeah, I think it's challenging, and particularly given the paucity of clinical data describing GR upregulation in patient tumors, to develop a large program around this target with really a paucity of information is challenging, and because we can see in patients responses with dexamethasone.
Aurora's data has never been validated in humans, has it?
Pardon me?
Aurora's data has never been validated in humans, has it?
I haven't seen any information. I think there was a recent paper by Charles Soares looking at the Stand Up to Cancer Dream Team, looking at patients who were never exposed to enzalutamide versus those who'd had prior exposure, where there was a slightly higher trend in GR expression in those who'd had prior enzalutamide, but I haven't seen compelling data in patients progressing on enzalutamide, still on drug, to say that target's highly upregulated.
Yeah, there's also that Mark Pomerantz had done a trial with RU46, stone cold negative. It's really interesting. To be honest with you, I think if it weren't Charles Sawyer's, we probably wouldn't be talking about it. I think it's just not a statement. I mean, he's got a lot of credibility, and
but it could be a correct observation, but the timeline in humans is such that when you're taking the ends and you progress, maybe you get a transient upregulation of GR that maybe is not transcriptionally important, and then maybe it goes down when you stop the enzalutamide. That's what I'm saying is your study that you've done with the post biopsies. Maybe that's what we'll see.
Yeah, the one thing that I might have commented on that was progesterone. When you concentrate a lot on the enzalutamide with abiraterone, you get a tremendous increase in progesterone. That is an agonist at a number of the AR mutants, such as 878, 875, etc. And Taplin's done beautiful work to show that it could be clinically relevant. And then, how many are PR driven, or how many are AR mutant driven by progesterone? That gets to be another way of addiction in this sort of steroid pathway.
And I think that's really where, without molecularly characterizing these patients, particularly patients who are still being exposed to the AR targeting agents, and trying to lump all them together with a single target, I think is likely to be unfruitful.
Yeah, but it's a cool area, and we're going to see a lot more work coming forward. So, thank you very much for